in some background mechanisms of symptoms in MS, so you'll be familiar with this. So, relapses, it's almost the hallmark of MS, a slow burning fire somewhere in the brain or the spinal cord. So depending on where it is, depends on what symptoms you might get, just weakness down one side, just numbness in both legs, just coordination on one side, just vision in one eye. And it's a slow burning fire. So it comes on over hours to days. It gets better over weeks to months. And ideally, it's something. Where did that come from? It's something new or profoundly different to what happened before. This is our sort of perfect, example of a relapse. And they're very obvious when they happen. They're more likely in people who are younger. When they're first diagnosed with MS, they get much less likely as you have MS for longer. As you get older, and we'll show you in a minute this sort of the long-term importance. Don't forget just day-to-day variations. This is where, imagine, to get a symptom, you have to go above this line. And some of the dots on scans don't go above that line. You see the dots, but you don't get a relapse. And sometimes they do, and then they get better. And then when you have a bad day, it just uncovers them. And this is not where did that come from. It's another one of my episodes. It's the same symptoms every time. Often my patients tell me times of tiredness, stress, heat, and infection. And then the bit we're interested in today, progression. Okay? By definition, it's a gradual change in symptoms over at least a year, independent of relapses. I'll tell you, from my experience, it's slow enough that I can't remember making diagnosis without being confident over at least 2 years. And we know on average from a study done in France that, from the time you tell somebody, I think this is progressive MS, and you ask them, now you know what it is, when do you think it started? The average gap is about 4.5 years. And that's a reflection of a couple of things. One, just how slow it is. And two, as you're coming to that time where the progression comes in, you get day-to-day variation. It can look like a series of relapses at first. It can be unclear when it first starts. After a while, it's clear that these are all the same one, and after a while they become persistent. And when you look back, that's progression. And then just a reminder to ourselves, just always bear in mind that it may be other things as well. So this is a little plot, a little diagram. So we've got disability levels and time. It's a little cartoon of how typically MS changes. And this is what about 2/3 of MS patients do. They may have one relapse here, and we call that a clinically isolated syndrome. If they have a second, that's definitely MS, or sometimes we can make the diagnosis with an MRI before then. And these relapses get less with time and less with age. Most of them, maybe about 2/3 of them, don't leave you with a problem. Some of them do. And it used to be thought that that's what progression was just accumulation of disability from lots of relapses. But actually, now we understand things better. We've had MRIs and we've got treatments and things are clearer. That's not what happens. There's a gradual change, and I should make that much longer and slower actually to show that. Not everybody gets it. Some people never get progression, and about 1/5 of people, they get primary progressive MS. So it's the same thing, but without the relapses. And in fact, if I was to plot this accurately, I should put that on the same axis, and it should go at the same rate and the same distance at the same ages. Okay, realistically, in terms of symptoms and progression and age, they look the same. We've had that point made already today. So to give I think this is the clearest illustration. This is some relatively recent data, although from a study that started in the 80s. So this is a group in London who had the foresight when MRIs first came around in the 1980s to scan all of their patients. And they wanted to know if you could predict MS after one episode, because at those times you needed two to be sure. And actually it was very helpful. You couldn't quite, but you could be 80% confident. And that's fine. They followed that up to 20 years. After that time, whether you're going to get MS or not, well, you either have or you haven't, but they carried on studying it, which was very useful. After 30 years, they looked at, we're not interested in whether you get MS then or not, but what we're interested in is how people do. And this is a really useful thing because it's after a hard point, a biological, plausible point, the first set of symptoms of MS. And so what we've got here, so there's a plot of all the number of patients who get to particular disability levels. Yeah, so the further along you go here, the more, can you see the point? So the further you move along to the right, the more disability these people had after 30 years. And I've tried to make this clearer, the original black and white publication, and put it in colors. So the yellow ones are the people who only ever had one episode. The blue ones are the people who develop relapsing remitting MS, but not progression. And you see, there's not actually a massive difference between them. There's a little bit, perhaps, but not a massive difference. We have one attacks or many attacks. What does make the difference is the green here. So the green is those patients who had progressive MS. So we explained earlier, it can be difficult to spot at one time. If you take that balcony view and look down and change over a long period, 30 years, it's very clear. And in terms of long-term disability, with a small number of exceptions, it's really about progression. Now, the difficulty is it's hard to spot. It's not as straightforward as these focal patches of inflammation. And I thought the best illustration of this is to show you some pictures. So we've got, this is a picture of somebody's MRI brain scan, and we're looking at the head cut across here, and you're looking from the front. So you're looking face on, this is the right, and this is the left. And we've got two scans. And if I flick between, sorry, I think my pointer on the wrong side. This is the right, this is the left. And if I flick between these two, hopefully you've got a fast enough connection, you can see that flicking. You can see the difference between the baseline scan done in this particular study and how this person was at 2 years. And this is actually quite a big change actually for 2 years. We'll bear that in mind. But perhaps the most obvious thing is these new patches here. So you can see, so we've got the brain here. We've got, these areas here are the fluid-filled spaces, the ventricles. They're just the fluid-filled shock-absorbing spaces in the brain. And these areas here are the MS lesions, the demyelination that you've heard about. And so, oops, so this one you can see is there on both. Some of these others appear. There's a few down here that appear. And these are the lesions. And these is the most obvious thing. These often cause relapses, and they're obvious to see on an MRI scan. Progression is a bit more difficult. It's not a focal patch of inflammation. It's a gradual wearing out. It's degeneration rather than neuroinflammation. And there's a more subtle thing that you might see here. If you look at these ventricles again, as I flick between the two, you see they get a bit bigger. Or there's a space here, it goes a little bit darker because there's more fluid there. What's happening here is the brain is getting a little smaller. We think we're losing volume, we're losing nerves. And we think this is our best substrate, our best way of seeing progression. It's very clear in this case, in many people, it's not, you can't use MRIs to look at this. The brain is considerably smaller at different times in the day than it may shrink over the course of years. So you can't use it clinically, but it's a nice illustration here, I hope. So, I mean, this is a slide that I think would have been fascinating and exciting to people 25, 30 years ago, just showing the number of treatments that have come on since the first one in 1995 for relapsing remitting MS. And this is something we hear, I think with some justification from patients suffering with progressive MS, that there's lots of treatments for relapsing remitting. And it's not as though people haven't tried. You've heard some examples of continuing efforts to try and find something to treat progression. This is a slide done in 2015 looking at phase 3 that you've heard about, trials in secondary progressive MS over 17 years. There's 18 of them here. Each of these costs a few £1 million. So people are prepared to put in the time, the money, the investment. Unfortunately, these were all negative. And all the ones in green, and this one should be green as well, are things that work in relapsing remitting MS. And these ones here in orange, I think, are things that I think probably do work in relapsing remitting MS that don't work in progression. So it's more of a challenge. And I guess that might make sense if you think, treating inflammation, treating inflammatory diseases might be a little easier for us than treating wearing out degenerative diseases. So I'm often asked the question, is there a cure? And is there a cure yet? Well, there isn't, but I think I can see what it might look like from here. And I don't think it's going to be one treatment for MS, one thing. So these are things that we can do now. Since the 80s, we've had, we know steroids can be effective in treating a relapse when it happens, although the body's quite good at doing that itself. All those those treatments that you hear about, and that slide I showed you, it's about relapse prevention. We weren't very good when we first came around. We got better and better at that where we need to, and we may take some risks. We are very good at now at preventing relapses. this is the next cab off the rank, and what we're talking about today, slowing progression. You'll never stop it unless you can also stop people getting older, because a gradual change in neurological function over years also happens as you get older. But you might stop the MS component, in which case you'll see a significant slowing. And then the bit I think that would be really exciting is repairing old damage. So we're beginning to make progress now on that third bar. So it's nice to be able to add a couple of things onto this old slide. Ocrelizumab for primary progressive MS. This is where your diagnosis does make a difference, because the trials were done in primary progressive MS for ocrelizumab and secondary progressive MS for siponimod. Neural repair, still science fiction as we currently stand. You've seen some ideas about how we might be able to do that, remyelination, etc. But I'm an optimist. I think we'll be able to do this. Whether it's going to happen in my career, I'm not sure. And then I'll leave some of the details of this to Dr. Elsoni. I think it's got some figures, but this is really exciting when it came out. The first successful phase 3 trial in progressive MS, in this case, primary progressive MS. So what you're looking at here is the amount of time to up to 216 weeks. So that's just over 2 years. And you've got 2 lines. And this is when people got significantly, got a little worse and stayed worse over 3 months. And that's the placebo line, this gray one here. So if your treatment did nothing, it would just run alongside here. If it stopped MS completely, it would run flat along the bottom. And that's where ocrelizumab is. So this is a high quality trial. It's difficult to know exactly what that means in practice. And I think that will become clearer over the next few years. This difference here, but it is a high quality trial, and there's definitely a difference. Okay, and we'll see what that is with time. And then a similar kind of plot for siponimod in secondary progressive MS. And then just going back to treatment, I don't want it all to be about these, because you don't. We mustn't forget this building has a roof. Okay, you can always treat the symptoms. Something we've always been able to do in the Walton Centre. We've always kept patients with progressive MS in MS clinics, because there's things we think we can do to help, but it's done a different way. So an illustration of this is, if you'll forgive me for bringing an English slide to a Welsh meeting, but I think the principles of this are relevant and illustrative. This is somebody's idea of what I think an aspirational idea of what optimum care of MS would look like. And it starts from the person with MS moving through community teams, regional centres, supra-regional centres, and starting from first symptom through to end of life care. And a lot of that is centred on the MS service that we provide from the Walton Centre. And there's lots of things I've ringed in blue that we do and is our predominant role, but there's lots of other things in red that we don't do. And in particular, this is partnership. People value specialist care, I hear, that we do, but they also value local care. And I think there's always a balance to be struck between those. Perhaps we can't get into a lot of detail here without a full team. I think we'd need the nurses, our therapists, our community teams to really get into the detail of that. But I hope the illustration is made. Wonderful. Thank you very much.
Thank you very much, Ian. That was really interesting. So am I passing now then to Dr. Elsoni?